Good evening, everyone. Greetings from Department of Nuclear Medicine, Amrita Institute of Medical Sciences, Kochi. I am Dr. Shanmuga Sundaram. It gives me immense pleasure in welcoming you all for this second lecture of Amrita International Lecture Series 2025 as part of our department's Silver Jubilee celebrations. A small introduction to our department started in 2000 as a single unit gamma camera department. We have grown over the last 25 years, and now we are able to offer gamma camera, Sentinel, the PET CT, PET MRI services. Apart from that, obviously, all the theranostics, the therapeutic services also to this part of the country, the state of Kerala. It is my honor to welcome and introduce our speaker today, Dr. Panitaya, one of the most prominent figures in nuclear cardiology specialty, who is doing yeoman services in the field of nuclear cardiology education. Dr. Panitaya is the Director of Nuclear Cardiology. She is the Education Chair and Diversity Co-Chair of Department of Cardiovascular Medicine, Mayo Clinic, Rochester, United States of America. She is the past President of Society of Nuclear Medicine and Molecular Imaging Cardiovascular Council, and she is the present President of American Society of Nuclear Cardiology. She has multiple publications in international indexed journals, and she is a most sought after speaker. Just to highlight that point, she is actually delivering as many as 9 lectures this week, and we are proud to have her as this lecture also is one of that. I take this opportunity to welcome Dr. Panitaya and also all the delegates, participants, the nuclear medicine physicians, the practicing cardiologists, the internal medicine specialists, and of course, the CVTS surgeons also. So she will be presenting the topic, the role of nuclear cardiology in this era of multimodality imaging, the diagnosis or the imaging of coronary artery disease. At the end of this talk, I shall be putting up the queries and questions from the chat box to Dr. Panitaya. So I request all of you to feel free to write your comments and more importantly, the questions in the chat box so that I can put it up at the end of this talk. Over to you, Dr. Panitaya. Thank you very much once again, and I take immense pleasure in welcoming you once again on behalf of the Indian nuclear medicine physicians, the cardiovascular surgeons, the cardiologists, and all the practicing clinicians of our state and country. Thank you very much once again.
Thank you very much, Dr. Sundaram, for the kind introduction. And I'm so incredibly honored to be invited to participate in this online Amrita International Lecture Series. So it's my great honor to join you today. And I'd like to also thank the audience for joining us. I just want to be sure you can see the slides. If there are any issues, please let me know.
We are able to see your slides perfectly, and we are able to hear you also.
Okay.
Thank you.
Very good. So over the next 45 minutes, I'm going to discuss imaging for coronary artery disease and the role of nuclear cardiology in the contemporary and multimodality imaging era. So these are my disclosures. I do have consulting roles with GE Healthcare, and I will be discussing flurpiridaz. And then I will also be talking about some of the unapproved tracers, F18 SIN2, O15 water, and XTR004, which are not FDA approved. So today we'll be covering these three learning objectives. First, we'll discuss the shifting paradigm of coronary artery disease epidemiology, including the impact of obesity and cardiometabolic disease, and evaluate how these changes challenge traditional diagnostic approaches. Then we'll critically appraise the role of PET myocardial perfusion imaging, or MPI, and myocardial blood flow quantification in addressing some of these evolving challenges. And determine their impact on CAD diagnosis, risk stratification, and management. And lastly, we'll develop strategies to enhance the clinical utility of nuclear cardiology, including the integration of PET MBF and to optimize cardiovascular imaging in diverse settings for ischemic heart disease. So, one of the most significant developments in the last few decades is the evolving paradigm of CAD epidemiology and clinical presentation. And this shifting paradigm is driven in large part by the global obesity epidemic. By the year 2035, it's projected that nearly half of the world's population, about 4 billion people, will be classified as obese. This dramatic rise will disproportionately impact populations in Africa and Asia, with women being affected at a higher rate than men. The rise in obesity and cardiometabolic disease is closely tied to a cardiac phenotype characterized by diffuse atherosclerosis, microvascular remodeling, and an overall poorer prognosis. So these changes present new challenges in diagnosing and managing coronary artery disease and really underscores the limitations of traditional diagnostic tools. So first, traditional stress tests, including our very own SPECT-MPI, may lack the sensitivity needed to detect balance ischemia, as you all know, and microvascular dysfunction. And as we shift our understanding of CAD, we recognize that diffuse atherosclerosis and microvascular dysfunction are increasingly common. Specificity may also be impacted as well. Second, conventional imaging methods often fail to fully capture the full extent of disease, and this can lead to underestimation of coronary pathology, especially in patients with diffuse non-obstructive coronary artery disease who remain at high risk. Third, both non-invasive and invasive angiography have resolution limitations that may prevent us from detecting subtle yet clinically significant abnormalities, especially those of a functional nature resulting from microvascular remodeling and endothelial dysfunction. So the anatomic approach has limitations in this regard. Another key issue then is the lack of myocardial blood flow quantification with traditional techniques and conventional testing. And without this, we rely on relative perfusion imaging, which can miss important patterns, particularly in multivessel disease and microvascular dysfunction. And we face challenges in identifying high risk patients. And this makes risk stratification more difficult. Then, of course, patient specific factors such as body habitus can impact diagnostic accuracy with attenuation artifacts and image degradation. And these specific factors don't just affect nuclear imaging, but they can also affect other non invasive diagnostic modalities such as stress echocardiography. So, with these limitations in mind, it's clear that we need advanced tools that improve diagnostic precision, enhance risk stratification, and ultimately drive better patient outcomes. It's taken decades for true recognition, but PET MPI has undoubtedly answered the call. And PET MBI with myocardial blood flow quantification is the most validated tool for the contemporary assessment of CAD. It's transformed how we evaluate chest pain patients, particularly those with diffuse atherosclerosis and microvascular dysfunction. And over time, a strong foundation of evidence has demonstrated PET MPI's value in diagnosis, prognosis, and risk stratification. But what really makes PET the superior tool in this space includes several distinct characteristics that set it apart from other modalities. The evidence base is extensive with 2,500 peer-reviewed publications, many highlighting the clinical value of PET MPI. We will not have time to go over all of them, and we'll just go over a few of these studies. So as you all are very familiar, PET's unparalleled precision stems from a combination of advanced physical and physiological characteristics, PET tracers, have high extraction fraction and high energy photons, and PET has superior spatial and temporal resolution, high count statistics, and robust built-in attenuation correction. So these advantages translate into superior image quality for relative perfusion imaging, high interpretive certainty, and excellent diagnostic and prognostic value. And PET does this efficiently with low patient radiation exposure for MPI and streamlined protocols, particularly when compared to SPECT MPI. But what truly sets PET apart is its ability to provide accurate and reproducible measurements of absolute myocardial blood flow. This is a game changer in today's clinical landscape, with diffuse atherosclerosis and microvascular dysfunction really being common challenges for us. So PET's role in contemporary CAD is, again, the ability to provide highly reproducible absolute myocardial blood flow measurements. Reproducibility is really critical, whether we're using N13 ammonia or rubidium-82 or flurpiridaz. We need confidence that the measurements are consistent and reliable across different scans, operators, and institutions. And these Bland-Altman plots demonstrate just that, showing the strong agreement and minimal variability in MBF measurements with both N13 ammonia on the left with about 10% variability. This comes from data from our own lab, and rubidium-82 on the right with a bit more variability, but still reinforcing the reliability of PET MBF measurements in clinical practice. We also have data from multiple studies examining MBF and MFR, which is stress flow divided by rest flow, in healthy volunteers. First, with N13 ammonia, as shown here, resting flow on average 0.7, stress flow 2.6 in healthy volunteers, myocardial flow reserve, stress flow divided by rest flow, 3.5 on average, again in healthy volunteers. The measurements are all very consistent across diverse populations if you look at different studies across laboratories, software, hardware, and stress agent. We see a similar pattern with rubidium-82. Resting and stress flow, along with flow reserve, remain remarkably consistent. And this reinforces the robustness and reliability of PET MBF measurements, again, regardless of the tracer use. And then this is really essential for us because it forms the foundation for defining normal values, which in turn allows us to accurately detect abnormalities. And as we integrate new tracers, these established principles ensure that precision and reliability remain at the core of PET imaging. So now that we've highlighted the consistency and reliability of PET measurements, let's focus on what PET MBF, myocardial blood flow, actually measures. This image illustrates the coronary circulation. PET MBF reflects total blood flow through the entire coronary circulation. And this is the epicardial coronary arteries, as well as the small arteries, the arterioles, and capillaries. And this is quantified in mils per minute per gram of myocardium. This is with using dynamic acquisition and validated compartment models. Flow reserve, again, also has many terms: coronary flow reserve, myocardial flow reserve, myocardial perfusion reserve, myocardial blood flow reserve, is simply the ratio of stress to rest flow. And regardless of the terminology, the concept remains the same. So PET, MBF, and MFR are unique in that they integrate the effects of both focal and diffuse epicardial and microvascular disease. While flow reductions indicate abnormal physiology, they don't always pinpoint whether the cause is epicardial, microvascular, or both. And so, because they are not measuring the same things as some of the invasive measurements, such as FFR or IFR, they may not always correlate one-to-one with epicardial stenosis, as microvascular dysfunction can coexist with epicardial atherosclerosis. And so they may not also correlate with the other measures, but they do highlight PET's unique ability to provide a very comprehensive insight into the full spectrum of CAD. So while relative perfusion, the image might suggest single vessel disease, PET MBF could suggest multi-vessel disease, given its higher fidelity, and we see this in everyday clinical practice, and I'll show you an example of that. But really, flow measurements alone may not always pinpoint the exact cause of a problem, and we need to integrate flow findings with other data and consider the clinical scenario, just like anything else we do. But understanding this basic concept is essential to recognizing how PET MBF and MFR provide critical insights into the full spectrum of CAD. PET MBF then offers several advantages over relative myocardial imaging, as listed here. It improves the diagnosis of epicardial CAD, as well as the extent and severity of disease, including balance ischemia. It plays a critical role in identifying coronary microvascular disease, which relative perfusion imaging often misses. It also helps to identify cardiac allograft vasculopathy in heart transplant recipients. It provides prognostic insights, improving risk stratification and guiding management decisions, whether it's for medical therapy or revascularization. And lastly, it confirms the effectiveness of pharmacologic stress. There have been many, many papers published on this. I've selected just 3 published studies for us to review. The first is this table from a review published in the Journal of Nuclear Cardiology, which highlights the incremental diagnostic value of PET MBF. The key takeaways from this slide are: 1, absolute flow quantification shown in the second to last column improves diagnostic performance compared to qualitative perfusion imaging shown in the column before. Just take, for example, the second row and 13 ammonia, quantitative PET diagnostic accuracy 92% compared to relative perfusion imaging 79%. And the second key point is that multiple tracers, as shown here in the first column, demonstrate this advantage with significant improvements in accuracy, net reclassification, and C statistics. So quantification helps us to detect multivessel disease, for example. This is against angiographic data as the reference standard, and this helps to address limitations of relative imaging. This second study from the Brigham and Women's Hospital demonstrated the incremental value of MFR over relative perfusion imaging alone in predicting cardiac mortality. So patients in the lowest tertile of MFR, defined as 1.5 or less, had a 5.6-fold increased risk of cardiac death compared to those in the highest tertile, greater than 2, even after adjusting for traditional risk factors. And this trend holds across all levels of perfusion abnormalities, including those with normal MPI and those with mild to moderate abnormalities and those with more severe abnormalities. So what this tells us is that even in patients with normal or mildly abnormal perfusion findings, a reduced MFR over here is identifies a high-risk subgroup that would otherwise go unrecognized. And this makes PET-MFR an essential tool for refining risk stratification and guiding clinical risk decision-making beyond standard perfusion. The third study showed that combining MFR and stress MBF provides a more precise risk assessment, guiding tailored management decisions. Here, patients were classified into 4 quadrants based on MFR of less than 2 and stress MBF less than 1.8. The worst outcomes occurred in this left lower quadrant, the pink one, where both measurements were impaired, and highlighted by the red dots here are cardiovascular deaths. So this is the group of patients with the highest risk. In contrast, the best survival was in the upper right quadrant, where both metrics were preserved. So this reinforces how combining MFR and stress MBF provides a more precise risk assessment, and this then can help guide and tailor management decisions. And in this study of nearly 12,600 patients, patients with MFR of 1.8 or less, as shown here by the arrow, had a clear survival benefit from early revascularization in the red line compared to medical therapy, whereas those with MFR greater than 1.8 over here did not have the same advantage. And this effect was consistent across different levels of ischemia and revascularization strategies. So integrating MFR into routine PET myocardial blood flow, myocardial perfusion imaging can refine diagnosis, prognosis, patient selection, and optimize management strategies. The added value of integrating coronary artery calcium scoring with MFR to refine cardiovascular risk was highlighted in this study of about 4,000 patients. So, for example, when coronary artery calcium score exceeded 400 and MFR was less than 2, the MACE rate rises sharply to almost 6%, emphasizing the significantly higher risk in this subgroup. And this is a powerful example of how combining nuclear cardiology with CAC enhances risk stratification in this contemporary era, and it provides a more comprehensive assessment beyond either metric alone. As I alluded to earlier, interpreting PET MPI and MBF studies require a comprehensive approach that integrates multiple key imaging components, and these include the relative perfusion images to assess focal disease, epicardial disease, ECG-gated images for evaluating LV function and volumes, flow measurements here to identify diffuse atherosclerosis and microvascular dysfunction, and non-contrast CT to assess coronary artery calcification. This can be done quantitatively or qualitatively. Additionally, incidental findings may identify other important aspects such as lung disease or malignancy that may provide very important clues to the patient's symptoms. And so I think that this ties in directly to our overarching theme of multimodality imaging, and successful management of CAD does rely on recognizing underlying disease mechanisms, leveraging the innovative capabilities of PET-CT, and strategically integrating nuclear cardiology then with other imaging modalities. We can better then be equipped to refine the diagnostic and management strategies and ultimately deliver a more precise, personalized approach to patient care. So we've seen how PET MBF and MPI are now recognized as essential tools, um, particularly in assessing ischemia and microvascular dysfunction and risk stratification in the papers in publications. How does this translate into real-world clinical decision making? So let's look at two illustrative cases that highlight how PET MBF provides unique insights beyond relative perfusion imaging, guiding both diagnosis and management. So the first case is a 76-year-old man with possible cardiac chest discomfort. He has a number of cardiovascular risk factors, uh, including hypertension and dyslipidemia. And note that his BMI is 48. He also has orthopedic limitations. Because of his symptoms, he was referred for a regadenoson PET MPI performed with a PET CT system. In our laboratory, it's a dedicated one for cardiac use. And N13 ammonia, we have two on-site cyclotrons. And so we're able to produce N13 ammonia for our PET MPI and MBF studies. His stress ECG was negative. I have performed all the necessary quality control steps for you, and there were no concerning issues. And here are the images in grayscale in standard views, stress on top, rest on the bottom of each pair of images. We do see a very small fixed inferior defect where I'm pointing, if you can see my pointer, and this is with stress and with rest, so this is fixed. This small inferior apical defect is apical thinning or partial volume effect, and this is a normal variant that we see very, very often with N13 ammonia and also with F18 fluoropyridaz, the newly approved tracer. As we move towards the base, the perfusion remains homogeneous throughout the left ventricle, but The TID ratio is borderline. It's a 1.14, and this indicates possibly some post-stress LV dilatation. For PET in our laboratory, we use a cutoff of 1.13. And here are the images in the color scale for those of you who like to view the images in this scale. The fixed apical and inferior defect is seen again. It's a normal variant, again, for both N13 ammonia and F18 flurpiridaz. And again, we have normal perfusion elsewhere with no evidence of stress-induced ischemia or infarction. And here are the ECG-gated images. The LVEF was borderline around 48%, but there were no specific regional wall motion abnormalities at rest or with stress. And with stress, the LVEF did not increase very much at all. So despite the normal perfusion images, with dynamic imaging and kinetic modeling, we can see here that stress flows and flow reserve are markedly reduced. We use a cutoff of 2 for myocardial flow reserve, or MFR, and again, as I pointed out in one of the studies, 1.8 for absolute flow, stress flow. And here, global MFR was only 1.5, well below the 2 threshold, and likewise, stress MBF was only 1.1, also well below the 1.8 threshold. And this was true across all of the different coronary territories. In addition, the patient's low-dose non-contrast CT showed evidence of severe multivessel coronary artery calcifications, very dense, particularly in the left main, proximal LAD, and proximal RCA. So putting everything together, despite the relatively normal images, flow and flow reserve were markedly reduced. There was TID and severe multivessel coronary artery calcification. He was felt to be very high risk despite the normal perfusion and was referred for invasive coronary angiography. This did indeed show very severe left main disease with post-stenotic dilatation into the origin of the LAD and circumflex. He also had a ramus of 70%. The RCA had catheter damping with engagement and was thought to have an 80 to 90% stenosis. He underwent bypass surgery and had improvement in his symptoms and is doing well. So this case really illustrates the many, many reasons to incorporate the measurement of myocardial blood flow when performing PET MPI to improve the assessment of the extent and severity of epicardial disease, which we actually would have missed without the flow because the relative perfusion images were completely normal. This is quite rare with PET imaging, probably about 2.6% in one study published in JNC, and to improve risk stratification and enhance selection of patients for coronary interventions or medical therapy. So the second case is a fairly typical case that I see in our complex chest pain and coronary physiology clinic. This is one of the most challenging assignments that I have in my clinical practice at Mayo Clinic in Rochester, Minnesota. This is a middle-aged woman with chest discomfort and dyspnea, both occurring on exertion and with mental stress. She has multiple uncontrolled CV risk factors and a BMI of 37. She has had extensive testing, as is quite typical for this type of patient that I see. Her prior stress SPECT images were negative, but she had an ischemic stress ECG during treadmill exercise testing and also developed angina on the treadmill. A prior stress echo was negative. CTCA showed no significant obstructive coronary artery disease. And she also underwent extensive GI workup, which was entirely negative. And at this point, she was really frustrated and very depressed, and she was referred to us for a second opinion. She was found to have significant diastolic dysfunction on echo, and microvascular disease was suspected. She was referred for a regadenoson PET MPI with myocardial blood flow quantification. So first, again, I've done all the quality control steps for you. And recall here, BMI is relatively high as well as in the last patient, and we have beautiful N13 ammonia images. And there was no evidence of stress-induced ischemia or infarction. TID ratio was 1. Here are the images in color. Again, completely normal. Apical thinning is evident again in this color scale, but this is again a normal variant for N13 ammonia and F18 flurpiridaz. And so a normal study so far. I'm not going to show you the wall motion, but despite the normal perfusion images, stress flows and flow reserve were markedly reduced. Recall the cutoff of 2 for reserve and 1.8 for absolute stress flow. And so her measurements were very low. This is well below 2 at 1.3, and this is well below 1.8. In addition, however, her low dose non-contrast CT did not show much coronary artery calcification, a little bit in the LAD, but certainly not as much as in the first case. And we also know from a prior CTCA that she did not have any significant epicardial coronary artery stenoses. So at this point, she meets Covada's criteria for microvascular angina, and she has the 4 features that are needed to have definite microvascular angina, which include not having any significant epicardial disease greater than 50%, symptoms of myocardial ischemia, which she had, objective evidence of ischemia. She had that with the ECG changes during an episode of chest pain on the treadmill exercise test, and she has evidence of impaired coronary microvascular function with the stress myocardial flow quantification. So I think with this, we could have just treated her for microvascular angina, but she had come to see us from very far away, from Alaska. So it was decided to proceed with invasive studies for confirmation. And at baseline, she had mild disease in the right coronary artery system, and also in the left system with the most severe finding in the mid-LAD of 40%. We perform vasomotor testing or provocation studies with intracoronary acetylcholine. She had no severe epicardial spasm, but with increasing doses of acetylcholine, she did have her typical angina symptoms and downsloping ST segment depressions of about 1 millimeter in multiple leads, suggesting some microvascular spasm. And then she also had adenosine, and her CFR was markedly reduced at 1.3. This was the exact same number as our MFR of 1.3, and IMR was 34. So the diagnosis of microvascular angina was confirmed, and she received treatment for that, which is a lot of medications, as well as kind of a very comprehensive approach to her chest pain syndrome. So this second case nicely illustrates the role of PET MPI and MBF in identifying microvascular disease, which is an increasingly recognized entity in the current CAD landscape. So for all the reasons that I've discussed and the cases that I've shown you and the growing literature, PET MPI with MBF now holds top tier recommendations in major guidelines worldwide. And these are the US 2021 chest pain and the 2023 chronic CAD guidelines and the 2024 European guideline on chronic coronary syndromes. Both US guidelines I just mentioned now incorporate PET MPI and MBF. PET MPI is given a class 1 recommendation for intermediate to high risk patients presenting with stable or acute chest pain. And according to the latest US guidelines, PET MPI is also preferred over SPECT now when PET is available to enhance diagnostic accuracy and reduce the likelihood of non diagnostic results. This is a 2A recommendation, which means it's very reasonable to do. Additionally, when patients undergo stress PET MPI, the guidelines also recommend adding MFR to improve diagnostic accuracy and enhance risk stratification. So this is another 2A recommendation. Lastly, both the chest pain and chronic CAD guidelines recommend using stress PET MPI and MFR to diagnose microvascular dysfunction and further refine risk stratification in those patients, just like I showed you in that last case. Also a 2A recommendation, very, very reasonable to do, and we are doing that in our clinical practice where available. The latest ESC guidelines for chronic CAD also provide 3 Class 1 recommendations for PET MPI. This is similar, the first one, to the US guidelines, preferring PET over SPECT for intermediate to high risk patients. And then measuring the calcium score, either qualitatively or quantitatively, from the CT transmission images to detect both obstructive and non-obstructive CAD, and recommending PET to identify patients at high risk for adverse events. These are all class 1 in the European guidelines. There's also a 2A recommendation to consider PET MPI for microvascular dysfunction, so very similar to US guidelines and very much like the patient I presented to you. So, despite all of the evidence and the guideline recommendations, even in the United States, PET MPI and MBF remain underutilized. And this was shown in the study published in the Journal of Nuclear Cardiology last year by former past president of ASNEC, Dr. Almala. So in 2022, Medicare was billed for a total of just over 212,000 PET MPI scans. In comparison, over 1.3 million SPECT MPI scans were billed. This is 6 times more than PET MPI. You can also see where the other modalities fall with respect to Medicare billing. Second, from that same study, 2 more important findings were reported. First, of the roughly 212,000 PET MPI scans billed for in 2022, only half were performing using a PET CT scanner, indicating that perhaps older equipment is still widely used for PET MPI. This also means that many centers are missing out on the benefits of combining perfusion, MFR, and CAC assessment, which I showed you was very important for patient management and prognosis. And then non-contrast CT can also provide key insights regarding extracardiac findings, those incidental findings. And so I think increasing the adoption of PET CT would help us realize more of these benefits. The second surprising finding is that only about 40% of the PET MPI cases included MBF measurements. Some centers may have performed but not billed for it, but there is now a code for it, and there's actually very healthy reimbursement for it. So they're sort of leaving some things on the table, but it highlights the need for more education about cardiac PET strengths. And I think that the value proposition for PET MPI is really truly MBF measurements. And so without it, severe multivessel disease and microvascular disease could be missed. So, PET MPI offers tremendous clinical value, but there are several challenges that need to be addressed for greater adoption, even in the United States. There's a very high cost of entry and ongoing operational costs that can be prohibitive for many institutions around the world and many practices. Availability of tracers, particularly in certain regions, can be limited, and most patients undergoing PET MPI require pharmacologic stress until now. The overall complexity of the technique and the need for familiarity among both referring providers as well as imaging readers pose additional barriers. In the United States, we have challenges with insurance pre-authorization, especially from private payers, and this further complicates adoption across the US. And around the world, PET is sometimes not available or affordable. There's also limited availability of dedicated cardiac PET cameras in many facilities, and this limits broader use. And lastly, we face a gap in randomized trials that could further validate PET's utility and effectiveness. And so these challenges present a call for innovation and education. And by addressing these barriers, maybe we can unlock the full potential of PET MPI in clinical practice globally. And having said that, there have been some developments. The first is FDA approval of F-18 flurpiridaz. This is a very exciting time for nuclear cardiology because for over 30 years that I've been in nuclear cardiology, we have not had any new FDA-approved SPECT or PET perfusion tracers. And so for several decades, we've been working with just rubidium-82 and N13 ammonia, which have added tremendous value, but they've been limited by the need for a costly generator or an on-site cyclotron because of their short physical half-lives. But now we have F-18 flurpiridaz. It has a physical half-life, as you all know, of 110 minutes. And so even though it's cyclotron produced like ammonia, the cyclotron does not have to be on-site because of the longer physical half-life. And the unit doses can be shipped from regional cyclotron facilities. This means potentially expanded PET MPI access not only to low, but also to high volume imaging centers like ours, where we are trying hard to grow the practice, but we're limited by how busy our cyclotron is for all the oncology tracer production. Another advantage of flurpiridaz is its longer physical half-life enables exercise treadmill testing. While it's feasible to perform treadmill exercise testing with ammonia, you don't want to be in the lab when we're doing that. It's not very practical. It requires a lot of coordination. With flurpiridaz, exercise testing will be easier, but we will lose the ability to quantify myocardial blood flow because we will not be able to perform the dynamic imaging within the scanner, the gantry, while the patient is exercising on the treadmill. And PET MBF is really the value proposition of PET MPI. Another major advantage of flurpiridaz is the increased sensitivity for detection of ischemia, even with relative perfusion images. And this relates to the linearity with flow compared to several other commonly used tracers. And you're all very familiar with this graph. If we compare with sestamibi, because of the non-linear roll-off phenomenon between blood flow and tracer uptake at high flow rates, even when there is a significant stenosis and flow reduction, the difference in uptake between ischemic and normal myocardium really can become less pronounced, and ischemic myocardium may appear similar in intensity, as shown here for to the resting images. And this reduces the ability to detect relative perfusion defects. Contrast this with flurpiridaz, which has a much higher and more linear extraction fraction, and it can then track uh, myocardial blood flow even at high stress flow. And this allows differences to be detected more easily between normal and ischemic myocardium. And this is more clearly appreciated in these images, relative perfusion images from the same patient from one of the trials, where we see much better defect resolution with F-18 flurpiridaz as compared to spec-sestamibi, again in the same patient. So the pivotal trial that led to FDA approval of flurpiridaz is shown here. It enrolled 730 patients. I was involved in this trial. Each patient underwent a one-day rest stress flurpiridaz study or a 1 or 2-day SPECT MPI, and all had invasive coronary angiography. There were 3 blinded readers. They were blinded to even the CT findings, so they could not look at the CT for coronary atherosclerosis. They were blinded to clinical information and only had the relative perfusion images, no flow. So for overall detection of epicardial CAD, defined by 50% stenosis on ICA, sensitivity and specificity of flurpiridaz PET in the blue bars were significantly higher than the pre-specified threshold. In addition, sensitivity of flurpiridaz PET was significantly higher than SPECT, and its specificity was non-inferior. ROC analysis also showed that flurpiridaz PET sensitivities were significantly higher and specificities were non-inferior than those of SPECT in women, and in patients with a BMI of greater than 30. Remember the obesity epidemic. Accuracy was also higher in diabetics, but this did not reach clinical statistical significance. Flurpiridaz PET was also superior to SPECT with respect to image quality, diagnostic accuracy, and also had lower patient radiation exposure. And so in the last few minutes here, I just wanted to show you here one normal flurpiridaz image from one of the trials. Because of the higher contrast resolution and other properties, the LV cavity appears larger. If you've been looking at conventional SPECT all day and switch to flurpiridaz or N13 ammonia, you're going to see this change. Tracer uptake is also more homogeneous. Papillary muscles are usually more visible and is usually better visualized at rest than with stress. Doesn't mean that there's ischemia if you do not see papillary muscles with stress. Another very important finding is apical thinning or partial volume effect. I showed you this with ammonia as well, but readers must be very careful not to overcall this. There can also be some physiological subdiaphragmatic activity, but this rarely interferes with interpretation. RV uptake is often present as well in normal, so don't overcall that as well as being abnormal. Gated wall motion shows both segmental brightening and excursion in normal hearts. Then a few abnormal studies. Here's a patient from one of the trials. BMI is 46 and she has severe angiographic RCA disease. SPECT images look relatively normal, whereas flurpiridaz images clearly show abnormalities in the inferior wall consistent with ischemia. So better defect resolution. Another study, again with severe left main disease from the same patient, and there is not very much to see on the SPECT images, but clearly with the flurpiridaz images, there's a very large, reversible, severe apical, anterior, interseptal, and lateral defect not appreciated on the SPECT images. So I think so far you all agree that F18 flurpiridaz PET has superior defect resolution, and we have higher interpretive certainty. It's also important that we must continue to innovate and to maximize the potential of PET imaging in nuclear cardiology. And now, after nearly 3 decades without any new FDA-approved perfusion tracer, we have 2 other F18 perfusion tracers in development. We have one from China called XTR004, and the other from Poland called F18 SYN2, which just had its first human study published in the Journal of Nuclear Medicine the day before yesterday, March 6th. So congratulations to the whole team. I was fortunate to be a part of this. And so all of these developments mark a truly exciting time for our field, and we have the potential to expand access to PET tracers globally. We also have other innovations. This is the novel automated O15 water delivery system that's self-shielded. It connects to an on-site cyclotron, producing, dosing, and injecting O15 water directly into the patient. And there's also new analytical software for post-processing of O15 PET images. And this is all being tested in the phase 3 rapid water flow trial to gain FDA approval. Mayo was the first site in North America to install the device and study the very first patient. So many other innovations are ongoing, including those with tracers, hardware, software, AI, hybrid imaging, and so many other developments for PET MPI. We do not have time to discuss them all, but it's extremely exciting, and I show you just a small fraction here of the innovations that are ongoing. And ASNEC is helping to educate and increase awareness among our practitioners in the nuclear cardiology community with many different educational resources for both cardiac PET and hybrid nuclear imaging. You can see here, this will be in my president's message in April of 2024, 2025 here in the Journal of Nuclear Cardiology. And so In summary, the epidemiology of CAD is shifting with more diffuse atherosclerosis, microvascular dysfunction, and high-risk populations. Traditional diagnostic tools may not be sufficient to detect and risk stratify contemporary CAD. PET MPI with MBF is the most validated imaging tool for CAD assessment and has top-tier guideline recommendations in the US and Europe. But despite its advantages, it remains underutilized globally, highlighting the need for better access and adoption. Innovation, education, and advocacy may play pivotal roles in overcoming barriers to pet adoption. So, thank you very much for your attention. Again, I am so incredibly honored to have been invited to deliver this presentation, and now I can take some questions.
Thanks a lot, Dr. Panitaya. That was an extraordinarily high quality, accelerating, lucid talk on the relevance of PET imaging in the myocardial perfusion studies and also in the quantitation in the day-to-day practice and in the diagnosis of coronary artery disease and microvascular angina and dysfunction. I have got some queries through my WhatsApp. Personal mails, messages have been sent. So let me start with that. Some of the specific questions, especially very relevant to Indian settings, are we don't do routinely the myocardial blood flow estimations using the PET studies. Rather, more extensively, we do SPECT studies only. So in that context, at least in dedicated cameras, can we do a SPECT myocardial perfusion blood flow studies? And do you feel that is equivalent, if not perfect, with the assessment by the PET studies? Or is it clinically relevant? Is it clinically possible? And do you advise or advocate the use of SPECT MBF studies?
That is a great question, and I had wanted to touch on that, but I think the talk would have been too long. So SPECT MBF is feasible, and there have been some early data suggesting that it is can be accurate and reproducible, but there is really still not much data on the clinical application and the prognostic value. It's certainly not to the level as PET MPI. So I think if you have PET, it's preferred that you quantify SPECT MBF with PET rather than with SPECT. It is with most of the more modern scanners, such as CCT systems, you can do it, but I think that it will change the workflow as well if you do quantify myocardial blood flow with SPECT. So I would say, in short, it's not quite ready for prime time, the same way that PET MBF is ready for prime. It's been used clinically now.
The second question is from practicing cardiologist. You have highlighted the relevance of microvascular dysfunction as the cause for ischemic heart disease. In day-to-day practice, is there any data which says how much percentage of patients are exclusively due to the microvascular dysfunction, or is how many percentage of patients ischemia is due to epicardial stenosis, or a combination? And do you feel what is the right investigation that is to be performed in these type of patients who are having microvascular dysfunction? Especially this is from a cardiologist who feels, is there not a role for any non-nuclear investigations in their day-to-day practice?
Okay, great. A lot of questions in one. I think the first question was maybe the incidence or prevalence of microvascular dysfunction, and it is an increasing problem, especially as we know, with the obesity epidemic. And the typical phenotype is the patient with diastolic dysfunction and obesity. I think that most of those patients have some degree of microvascular dysfunction. I think the majority of them do. And we may not have detected this in the past, but as we perform more and more of these types of studies, it's become clear. They certainly have symptoms that may be compatible with that, with some chest discomfort and dyspnea exertion. And I don't think it's all due to HFpEF, that some of these patients actually have uh, microvascular dysfunction. So I think that we are seeing this to be much more common than previously thought, and maybe up to even 50%. In addition to that, often these patients do have some degree of epicardial coronary stenosis. It's not severe. And so there can be a combined microvascular dysfunction and some epicardial stenosis. In addition to that, in patients with very severe coronary artery disease, epicardial disease, they can also have microvascular dysfunction. And there can also be some endothelial and microvascular dysfunction. For example, after you perform coronary intervention percutaneously on these patients, that there is a type of microvascular dysfunction, and we see some of those patients come back with symptoms compatible with ischemia, but they do not have restenosis, for example. So I think microvascular dysfunction is much more common than previously thought. We always used to just look at the epicardial coronary artery disease and thought that, when patients had symptoms, it was maybe not really due to anything ischemic, but I think we're learning a lot more. There were some additional questions to that. There were like three questions, but I don't
Yes,
remember
exactly.
them all.
So I will
Oh,
I will put it back once more. Apart from that,
okay,
I also have some new queries. So I will just put it for the brevity of time. I will just put
sure.
it together. The first one is so you have very nicely explained the superiority of PET MPI over SPECT MPI. So does it mean in your lab you have completely switched over to PET? That is number one. Number two is what is your experience with reference to PET MPI versus stress MPI for perfusion? What is the data? And the third
Yeah.
one is there a real role for, so does it mean that we are doing a very inferior and probably irrelevant investigation in the form of a myocardial SPECT? Because again, I am highlighting we don't have the widespread availability of the MPI's PET in our country.
Yes, that's excellent question. So if I had my choice, I would switch most of the patients to PET MPI because of the higher sensitivity. I do think we're missing disease in many of our patients with traditional techniques. Unfortunately, not we have one dedicated cardiac PET system, PET CT system. And even though we have 10 other PET CT systems and a PET MRI system in our institution in Rochester alone, we are very busy with oncology studies. But we are trying to get a second PET scanner, and we're looking at using different combinations of PET tracers to try to increase access. So access is an issue, but if I had my choice, I think I would switch most patients to PET. Remember that with PET, it is if you do not use flurpiridaz, it's challenging to exercise patients, and there is still a lot of really important information that we can gain from the exercise study. And so in some patients, we may still use SPECT, but the other option is that there is a study showing that you can just perform the PET study with pharmacologic stress and then do a separate treadmill exercise test. And this helps then to further risk stratify patients. The experience in our laboratory are PET versus SPECT. We have one of the new CCT systems that's our workhorse for SPECT MPI. And even with that system, I do think that sometimes without flow quantification, which we don't do routinely for SPECT MPI because we have PET, I think we have reduced sensitivity, especially for multivessel disease. I think there is a higher rate of balance ischemia with SPECT than with PET. With PET, rubidium PET, the rate of balance ischemia that you would not detect with relative perfusion images is about 2.4%, but you can usually detect the balance ischemia by quantitative measures and other measures on PET as well. So I think we miss some disease in those patients.
Dr. Panitaya, I have four more questions. So I
Okay.
hope you are okay with that. So one
Yes,
is
that's fine.
from one of my senior nuclear medicine physicians. He is giving a clinical scenario. He likes to know that in asymptomatic individuals with normal LV function at rest, what is the risk if stress MPI is normal and if calcium score is more than 400? He refers to a myocardial SPECT study.
So with the SPEC study, I think that the risk could be low, especially if they're completely asymptomatic, if they exercise, they have, total exercise capacity is still extremely important. And it may actually, what in the study that looked at combined PET MPI with flow quantification and exercise treadmill testing that is done separately, the patients who exercise very well on the treadmill still have very low risk and they may not actually need PET. So I think you have to choose your patients carefully. I think that with normal LV function, completely normal SPECT MPI, um, calcium score 400, if they exercise well, I think they may, you may be able to treat them medically.
Okay. Two more questions from a senior cardiac surgeon. The first one is how PET can be utilized by cardiac surgeons for non-consideration for CABG of multivessel disease, coronary artery disease, referred by cardiologists for CABG. What he means is patients have been referred for a CABG with the triple vessel disease, but those patients may not be in need for CABG. So how PET can exclude those patients with ischemia or include them with ischemia? That is one question. And the
Mhm.
next one uh, is utilization of PET MPI, MBF going to increase the burden of coronary artery disease to the society and decrease the success rate of the percutaneous interventions or CABG? Is it going to increase the burden of coronary artery disease in the society? And is it going to decrease the success rate of the percutaneous interventions or CABG surgeries?
Right. Oh, great questions. So the first of the two questions about using PET for CABG, for coronary artery bypass grafting surgery, I think that the situation where we use PET to say no most commonly is in the patient with ischemic cardiomyopathy and moderately to severely reduced EF. And in those patients, I feel that our cardiac surgeons often order a rest stress PET with FDG for viability assessment, in the hopes that it will not show significant myocardial viability, and then putting that all together with the other um, clinical characteristics of the patient, then they can say no to bypass surgery. So, for example, the elderly patient with an EF of, 30%, severe multivessel disease, they may have had prior CABG, they may have chronic kidney disease, they may have had a few strokes, they have diabetes. These are the patients that's maybe some of our cardiac surgeons maybe do not want to operate, and they ask for a PET study, and if it does not it shows mostly scar, they will use that information to say, okay, this patient has scar and is not going to benefit from revascularization surgery. Sometimes they are surprised and the patient does have viability, and they end up deciding, it's all shared decision making, a hard team approach, and then they have to decide whether to take that patient to surgery or not. The second question about utilization of PET MPI and whether we're going to see more burden of disease. I think we're kind of already seeing that. We do see that there is more diffuse atherosclerosis, uh, some of which I think is borderline. It's there. These patients are at high risk, and we perform IFR or FFR to try to determine whether patients will benefit from revascularization. And I think if without those, measurements, even in the cath lab or measurements in the PET lab, we may be performing revascularization and the patient does not respond because they have more diffuse atherosclerosis that does not necessarily respond to focal treatment by percutaneous intervention. So I do think that we see that. I see quite a number of patients in that category that I send to revascularization with percutaneous approaches, and they come back with more symptoms because they still have microvascular dysfunction and they also need medical therapy. They need risk factor modification. They need all of the lifestyle changes that are extremely important as well, in addition to the percutaneous treatments.
I have one more question from a practicing senior cardiologist and again a senior nuclear medicine physician. More or less, I am combining both. First one is being a cost conscious country where we don't have any type of insurance being covering this type of investigation. The cost of PET MPI is going to be a major limiting factor. So the practicing cardiologist wants to know which group of patients you will definitely recommend this test. That is one question. And the second one is clinically, we know most of the Indian patients have microvascular disease. All we need to know is whether intervention is required for epicardial vessel disease. So won't SPECT just will suffice in this scenario. So it may be a bit combative and maybe what you have shown, the data are pointing more towards PET MPI, but we are talking with reference to Indian scenario.
Yeah, and I think this is, I mean, these are great questions. These are things that I face every day in my practice as well, because we also have limited resources and we don't have uh, unlimited access to PET MPI. So, which group of patients? I I would say that definitely I work in a complex chest pain unit where patients are referred for a chest pain syndrome and they may have had multiple other workups in the past and still don't have a diagnosis. Um, and they may have HFpEF and they definitely sound like they have microvascular dysfunction, but they need a confirmatory test. They have been tried, with empiric treatment and it has not worked for them. This group of patients, I tend to refer for PET MPI. They're often slightly middle-aged to older women, but sometimes I see men as well. They're obese. So I think those patients definitely benefit from PET MPI. It can also be used more broadly in other types of patients, more obese and women. But if there is a patient who is asymptomatic, who does not have a lot of the risk factors, but you need to do a test for some reason, maybe a surgeon wants to operate on them for a high risk surgery, those patients, I would use SPECT for sure, SPECT MPI. I'm not looking for the higher sensitivity. And so I think it's balancing those patients. And certainly, there are times when I'm seeing community patients, and not all patients at Mayo Clinic come from thousands of miles away. For community patients, it's actually possible to start with empiric treatment or perhaps a treadmill exercise testing or SPECT MPI and see how they do with medical therapy. This is what the ischemia trial showed, that there's no need to rush into more advanced imaging or doing invasive coronary angiography. And it's all with shared decision making. And if you have the ability to see them back frequently, then I think it's also very reasonable to not start with the most advanced techniques. But the advanced techniques certainly, have the ability to help us risk stratify, but we have to balance everything with resources.
Thank you. You have given very elaborate and very useful, relevant answers. But still, I'm not going to leave you. Possibly the last question, technical question from two nuclear medicine physicians. The first one is which radioisotope you feel is better in terms of image resolution? Is it fluorine labeled fluorperidas or the ammonia? That is one question. And the second question is briefly, can you explain how myocardial blood flow quantification studies, that is the first pass studies, are being performed? This is the second question. And the third one in the same one is this myocardial blood flow absolute quantification values 1.8 for myocardial blood flow and myocardial flow reserve 2, are they established values, and does it have any difference with relevance to the population, like Caucasian on male,
Mm.
female, and age related?
Wow. Okay. All excellent questions. Let's see. I've written them down. All right. Number one, which tracer? I am a little bit partial to N13 ammonia because I've done a lot of studies on it. I've used them all. I've had experience with O15 water for several years. N13 ammonia. We also used rubidium 82 for a while. And so, but I am a little bit partial to N13 ammonia. Image quality is excellent. Count statistics are, I think, higher than compared to rubidium 82 because the physical half-life of N13 is a little longer. And because of the extraction fraction of N13 ammonia, I showed you it's actually quite close to flurpiridaz and to O15 water. That higher extraction fraction, it gives us really good myocardial blood flow quantification. It also does not have a very long positron track. We don't like that. Then there, it loses energy as it meanders around. So all in all, flow quantification in our laboratory is very, very stable and highly reproducible. Having said that, we really need the cyclotron to be on site to do it. So it's not feasible for all. We have 2 on-site cyclotrons, and it's still hard for me to grow the practice. F18 flurpiridaz, I think will be with the unit dosing could potentially supplement, but we have not used that in clinical practice. All the images I've shown you have been from the trials. And so I think we need to learn more about it in the real world, and we need more data on flow quantification with flurpiridaz. Are the cutoffs going to be the same for flow and flow reserve? Is going to be that 1.8 and 2 that I talked about? We're not sure yet. How is it performed? Uh, how is flow quantification performed? Always, always, when we're doing flow quantification, we need the patient to be in the scanner so that we can start the scanner before the tracer arrives at the heart region of interest. And in order to do that, we also need a bolus injection. We need to capture that. We perform dynamic sequences, and now it's mostly Liz mode acquisition for the newer scanners. And then we can then take the regions of interest and the activity, the time activity curves, and with kinetic modeling, using different compartment models that have been extensively validated, then we can get myocardial blood flow. So that's kind of how it's performed. Um, are the cutoffs different for different populations? I do think there are some differences. We try to simplify by saying 2 and 1.8, 2 for flow reserve, 1.8 for stress flow. But we know that in women, for example, rest flow, older women tend to have higher rest flow and their flow reserve may be a little bit lower. Um, Younger people may have higher reserve MFR. So in reality, we should probably be applying different cutoffs, slightly different cutoffs to different populations. I'm hoping that AI will help us with this. It's too difficult for us to do all of these computations in our mind. So, but when looking at the flow values in MFR, I am often thinking of these things and trying to make adjustments. But I'm hoping maybe AI would be helpful for this.
Thank you very much, Dr. Panitaya. I think still I have 3, 4 questions, but I'm stopping here. I think
Okay.
we are also exceeding your time. We really thank you from bottom of our heart for taking your time off in your very, very busy schedule and to be part of this Amrita International Lecture Series online, which has benefited a lot of my clinical colleagues and also nuclear medicine physicians. And I really thank you once again, both from the Department of Nuclear Medicine, Amrita Institute, and also on behalf of all the participants. Thank you very much. And I wish a great day ahead for you. Thank you very much.
Thank you so much. I'm so honored, really incredibly honored. And thank you to you for reaching out to me. And thank you to everyone who attended. You've been such a wonderful audience. So many questions, so much interest. So really, it's been wonderful to be with you this morning or this evening for you. Thank you.
Thank you very much, Dr.
Thank
Panika.
you.
Thank you once again, all the participants, and for all your questions. I am sure you have more questions which we can write to her later. And this particular recorded version is also available will be available in YouTube. So any of our colleagues, they like to see it, can see it. Thank you very much once again. Good night
Thank
to
you.
all. Thank you very much.
Thank you.